All right. So now we go for our final panel for today, which is Dr. Azlizawati Azil. She was graduated from the Queen's University of Belfast, UK, and continue her specialization in emergency medicine at USM. And she did few subspecialties such as cardiac ultrasound, resuscitative transesophageal echocardiography, basic echocardiography, basic lung ultrasound, ultrasound central vascular access, and ultrasound life support. She also actively involved as a speaker and publication. With the title COVID-19 Extra Tips, present to you by Dr. Azlizawati Azil. Please welcome.
Right. Thank you, Mr. Chairperson. Are you able to hear me loud and clear?
Yes, Doctor, very clear.
Okay, good. Can you see my slide?
Yes.
Okay, good. All right. Good afternoon and Assalamualaikum. So I hope all of you are still wide and awake. I know it's almost 12 o'clock in the afternoon. Right, so I have two news. One is bad news and one is good news. The bad news is that my slide is 48 in total, but the good news is that majority of what I want to present has been covered by the previous speaker. So just take it easy, right? Sit back, enjoy. We just go walk to the park, basically, right? No need to take any notes, right? So I'll share with the organizer the PDF form of my presentation. Okay, so COVID-19, right? This is pandemic, right? So there is no emergency during pandemic. So guys, slow down, think and plan. Right, so the concept is I would like to highlight is that this 3S concept, right? So no matter what you do, right, in your clinical area especially, this 3S, right? Basically staff, meaning yourself, your colleagues, right? The space, right? Your working environment, the staff, the equipment that you use. All right, you need always to think about it, all right? This three things is just to prevent yourself from getting infected and then from you to become a source of infection to others, especially to your colleagues and to other staff, right? So how's COVID spread? Dr. Chan already nicely spoke to you about it, right? So just one thing I want to highlight, right? Just by just speaking or breathing normally, you can, patient can spread COVID. So don't ask your patient to sing, especially, all right? Right, so I'm going to be highlighting, right, so on this AGP, right? So Dr. Chan already mentioned this a few, but I'm just going to highlight it further. All right, so going to skip this, all right? Everybody should be wearing masks, right? Healthcare workers should minimal at least wear surgical mask, facial, you already know that. All right, availability of COVID, yes, it does, all right? One study have found out that, okay, COVID-19, SARS-CoV-2, and also SARS-CoV-1, previously the SARS, it can be viable, all right? The virus can be viable up to 6 to 8 hours on plastic and stainless steel. So be careful, all right? So just make sure you always clean your hand, disinfected regularly, okay? All right, cleaning and disinfectant, all right, basic stuff. You know already this, basic stuff again. All right, so again, all right, Dr. Chan already mentioned about this. All these are the things that can cause AGP, right? But it's not limited only to this, all right? So, okay, nebulization, all right, during COVID era, all right? So definitely no, it's a big no, all right? Do not give naps, all right? Give either straight from MDI or change off MDI with aero chamber. All right, so this is one study, right? So basically these studies, some of it is actually been done way before the COVID era, right? So this is a recent one, right? Face covering mask, okay? As you can see that, all right? Even though the patient, especially if patient coughing, sneezing, if not wearing masks, right? You can see that many particles of air droplets are being dispersed, and this can leads to infection, all right? If let's say the patient just wearing a single layer mask, right? It reduces the aerosolization, but still present, right? The maximum protection is when the patient wearing a surgical mask properly, okay? So every time you see a patient in your ward, in your emergency department, make sure that all your patients should at least wear a mask, or even better, surgical mask. Right, so moving on, the next one. Right, so this is actually, again, 2007, way before COVID era. If you can see that, This is the air droplet or aerosolization dispersion occur during just a normal simple face mask. As you can see that the red area here is the maximum aerosolization happen, right? So if you're using 4 liter face mask, right, about 20 centimeter of length of aerosol going to be generated. 6 liter, again, more or less the same. But as you increase the number of liter per minute, you can see that the aerosolization and dispersion become more further. All right. So if you're using 10 liter, right, it can goes up to 40 centimeter, quite far, right? So it can increase risk of infection. Interestingly, right? So this is 2019, recently, all right? They find out that exhale smoke dispersion, right, using high fluorescent cannula, even though you're using at 60 liter per minute, right, it's quite not so bad, right? The smoke dispersion is only roughly about less than 30 centimeter compared if you're using Venturi mask. So in all, right, high flow nasal cannula seems quite safe compared to Venturi mask. Interesting, right? Okay. So now, we already know that by using a surgical mask, we can reduce the risk of transmission. Okay, so if there any benefit, right, if your patient really need an oxygen devices, right, to help them hypoxemia, is there any benefit, right, giving them a surgical mask on top of their face mask, nasal bronch, or high flow nasal cannula? Yes, this study have nicely shown you that. All right, so this side, okay, if you can see at the left side is when the patient was given surgical mask, and at the right side is when the patient not wearing surgical mask. You can see the red color jet is basically the air or aerosolization or droplets is the most and the maximum. Okay, even, all right, with your high flow nasal cannula, 40 liter per minute, you can see that it's very minimal aerosolization happen, all right? Compared to no therapy, even though the patient has no therapy, but if the patient breathing quite heavily, still aerosolization can happen. So the take-home message is that, yes, if the patient need oxygenation, yes, by all means, give them the oxygen supplement that they need, but on top of that, give them surgical mask as well. All right, so next question. All right, well, how do you apply this surgical mask to the patient? Okay, can you ask the patient to wear surgical mask first? Right, and then only that you apply the face mask, right? Like in this first picture, or you give the face mask, right? And then you put the surgical mask on top of that. Which one? Okay, so in this study, what they find out that interestingly, in terms of oxygenation, right, both the patient more or less had a same oxygenation, meaning that their SpO2 and their PaO2 from the AB are the same. So in terms of oxygenation, yes, you can give either first surgical mask first, then you apply the face mask, or you can give the face mask and then apply the surgical mask. The oxygenation will be the same, right? So what's the benefit? I don't know. If you ask me whether which one technique or method is better in terms of reducing aerosolization, I have no idea. But as long as you can have a good surgical mask fit nicely to the patient, you will definitely reduce the aerosolization, right? Either how do you want to use it? In terms of oxygenation, there is no much difference, okay? But of course, nasal prong, high flow nasal cannula, you need to give the patient directly. Only after that, you apply the surgical mask. Okay, and let's say your patient need a further oxygenation therapy, all right? You need to step up, right? Your patient are more hypoxic, more severe. How about NIV? How does this relate? Okay, again, these studies, all right, 2015, way before COVID again, right? They check, all right, so they test how does air dispersion between different interface of NIV, right? They test 2 types of helmet, right? Different brand, I guess. Yep, different brands, right? I'm not going to tell you which one. And also a facial mask, right? If you can see here, right, this first helmet, you can see a lot of leak around, especially at the neck interface. This one, all right, I think if you properly apply the helmet nicely, right, to prevent any leakage, right, it's quite good in terms of not producing much exhale air dispersion. But if you can see, if you have face mask or facial mask, it's going to generate a lot of exhale air dispersion, right? If you can see that both of these helmet, they are using double limb circuit, right? And especially if you're using a different method, all right? If you're using just single circuit for your helmet, especially, like in Ipoh, we only have inspiratory limb, and our expiratory limb is basically just a free flow, all right? So this also can be the source of exhale air dispersion. So I would suggest to you that you put a viral filter to your expiratory limb circuit for it to minimize the viral dispersion or transmission, okay? But in terms of your face mask, it's going to be very difficult, of course, because you're going to have a improper snug to your patient face and a lot of leakage. So it's very difficult to control in terms of a face mask, in my opinion. All right, so regarding COVID-19, all right, so this is a very interesting theory being put forward by one of intensivists from Italy, all right? If I can remember the name, is Gattinoni, all right? He is a very expert in ARDS and also recently about this COVID. He put forward this theory that in COVID, right, basically there is two types, right? They have a type L and type H COVID. All right, for the type L, most probably the cause of hypoxemia in this patient is because of vasoplegia, right? Because of the loss of ability of vasoconstriction of the pulmonary capillary, causing a VQ mismatch to the patient and cause the hypoxemia, compared to the type H, which is more similar to the common or true ARDS that we normally know. All right, so this type of COVID, all right, type of ARDS, right? So the type L is basically related to a low elastin, all right? It's a low lung weight and low recruitability. So most of the time, because it's quite dry, lung, the type L, normally a patient does not really need a high pressure, right? So maybe it just increase in FiO2 treatment, a good oxygenation, right? Maybe it's high flow nasal cannula because you can give a higher flow rate, right? Compared to the type H, all right, which is a high elastin, high lung weight, and also with a high recruitability, which is more similar to the traditional ARDS that we know. So this type of type H COVID ARDS might need a higher PEEP, all right, need a more prone positioning and definitely at least NIVs, all right, or most of the time they are usually intubated and needing a higher PEEP and also lung recruitability if indicated. Okay, so that's the difference, right? Per se, I think in the real life, all right, in the real clinical setting, it's very difficult for us to really categorize all COVID into this type L or type H. Basically, I think it's more like a spectrum of the disease, all right? When you have a type L, it's probably in the early phase of the COVID, where the patient is not yet so severe, but as the disease progress, the patient might deteriorate and become from type L, right, become a type H. So I think it's more like a spectrum. The idea that I think it was put forward is just to help us in terms of managing the direction of our basically management, whether to give just oxygen, whether to give a higher PEEP, or whether patient need early intubation. I think that is just the concept of I would like to highlight to you guys. All right, again, right, of course, we're talking about H and L types, all right? So in COVID, it's very difficult, right, with our PPE, all right, to have, to auscultate along with our stethoscope. All right, so of course, the standard diagnostic, diagnostic, I think the standard investigation will be a CT thorax, which is not going to happen, all right, normally unless the patient in ICU, right? So most of the time, at most, the patient going to get just a chest x-ray. But in emergency department, all right, what we can do now is we can do bedside lung ultrasound. All right? So there has many studies, all right, have shown that this ultrasound finding actually correlates well with your CT thorax finding. All right, so it means that we can use our lung ultrasound finding basically to, of course, not to diagnose, because we need our PCR, right? It's just to make the highlight that to the clinician, all right, regarding the status of the lung, right? We can risk stratification and also prognostication and follow up the progress of the patient. So I think that's ultrasound is very useful. All right, so one of the scoring that we can use to incorporate our lung ultrasound is this the lung aeration score. Right, of course, the patient, right, we can divide the chest wall, all right, into 6 areas at the right side, 6 areas at the left side. All right, based on some imaginary line, you have your parasternal line, okay, you have your anterior axillary line and also the posterior axillary line. Right, so got 6 zone or area at the right side, 6 zone or area at the left side. So you can basically say this is R1, R2, R3, R4, L1, L2 accordingly. All right, so what you're going to do is that you're going to put your probe, all right, transducer on each of this zone and score it. All right, the score is 0 to 3. Right, if you see a normal finding, what you should see is an A line, a sliding sign, and if you have C B line less than 3, right, that is score 0. Right, if you see multiple B line more than 3 with lines more than 3, you score it 1, and this equate to the interstitial involvement of the lung. In epilepsy, all right, you see a lots more B line, all right, coalescent B line. This is score 2, and it usually indicates an alveolar involvement. And lastly, right, this is more severe. If you see a consolidation, all right, hepatization or air bronchogram, this is score 3 and is indicate a complete loss of aeration. All right, so you score each zone. All right, so minimum number of scoring that you can get if the patient told everything normal, it should be 0, and maximum number meaning as a so severe. All right, the most severe one you can get 36. So you can use this scoring basically to follow up the progress of your disease and to monitor how's your treatment, whether it's effective or not. You can use this scoring to see the progression of your disease, and also to somehow to guide you in terms of what sort of modality you want to use to treat the patient. Either if the score is quite low, all right, patient hypoxic, you might just can give the patient some conventional oxygen therapy. If your lung aeration score is very high, then you might want to start patient on an IV. So it gives you some sort of idea how to deal with your patient basically in this area, because it's very difficult. Stethoscope, chest X-ray, very difficult to get in the early phase, right? So you can use a bedside lung ultrasound. Okay, so basically COVID patient or suspect COVID patient, all right, or any patient nowadays, like any patient with respiratory syndrome, we are considered them as a COVID antiproviral device, right? So this patient should be triaged in the respiratory zone, all right? So again, right, if you give your normal oxygen modality, try to use the minimal flow rate, all right, to achieve an adequate SpO2 and improve the oxygenation of the patient. But if it's not adequate, all right, the patient is not need urgent intubation, all right, so meaning still stable, you can try your high flow nasal cannula or your NIV. Right, so again, like Dr. Chan said, all right, so this is a WHO guideline, anything, all right, any respiratory, any oxygenation, any NIV that you are giving to the patient should be done in an isolation room, preferably negative pressure room, and the staff should be wear full PPE at least level 3, okay, for your own protection. Which one is the best? Okay, this is very interesting. So far, there is no consensus, right? But the surviving sepsis campaign guideline mentioned this, all right? So the first line, all right, if your patient need a step up from your normal conventional oxygen therapy, is the first choice possible high flow nasal cannula. All right, I think this is because it's produce less aerosolization, and you can apply surgical airway on top of that and prevent dispersion of aerosolization. I think that's the reason why it become the first choice. right? If you don't have NIV and if you think that your patient need a bit of PEEPs, right, need more pressure, okay, then you use NIV, all right? So which one is better? Helmet or your face mask, right? Again, no answer. I cannot find any which one is the best. But again, if you remember the previous slide, you can control aerosolization better with helmet, plus with your filter. So I don't have an exact answer for this. I think it's depend on type of patient you have, your setting, and your guideline in your own center. Okay. All right. So one thing about COVID or any patient, all right, if you put your patient on NIV, right, you really need to monitor your patient really closely, right? Because we do not want your patient to suffer, all right, and then at the end up needing intubation. All right, so I want to highlight to you the concept of PCL, patient self-induced lung injury. Okay, if you put your patient too long, all right, on NIV without any improvement, all right, we worried that the more you let the patient NIV, all right, if you put an NIV, the patient have no benefit, all right, the patient still breathing excessively, right, the change of the pressure, all right, from the fluctuance of the intrathoracic pressure can actually cause harm to the patient because of the strain and stress to the alveoli. So this is the concept of patient self-induced lung injury. The patient just going to enter to a lung injury vortex and going to further harm and injure the alveoli. So we want to break this cycle, right? So if your patient hypoxemia, you put your patient on oxygen, you give your patient on NIV, and it help the patient resolve the oxygenation, the patient respiratory improve, right? You may continue, but if not, right, you want to break the cycle to prevent this PCL, right? Again, how do you know whether your patient is okay with your NIV? All right, we have many variables. Okay, you have your respiratory variables in terms of oxygenation, right? You look at their SpO2, whether it's improved or not. Look at the respiratory rate, whether the respiratory improve or not. Using of accessory muscle, any tracheobronchial asynchrony, right? You want to see your patient overall, and also deterioration of the patient, whether your patient need vasopressor, and whether your patient has some sort of multi-organ failure, right? So this is the more subjective. We have a more objective in terms of to predict NIV failure, right? If you're using high flow nasal cannula, ROX index, you can use that. So ROX index basically your SpO2 divided by your FiO2 and your respiratory rate, then you will get a number. Number should be more than 4.8. All right, if it's less than that, right, so there's a high chance that your NIV is going to fail. And if you're using NIV, right, you can use HACO score, right? So basically HACO score is your heart rate, pH, Glasgow Coma scale. Basically H is heart rate, A is acidosis, C is conscious level, O is oxygenation, and R is respiratory rate. So if your patient score 5 or more, right? So that is indicate that NIV is going to fail, right? So you can use it to predict. I don't put your patient too long on an IV and not without improvement, right? Break that cycle, PCL. Okay, so what happened if your oxygenation, your NIV fail? You have no choice but to intubate your patient, all right? So this is what we call a protected intubation. Again, slow down, think, and plan, right? So by right, all of our department, okay, your center should have some sort of a checklist for intubation in COVID, right? You need to be prepared, you need to plan, and you need to practice because intubation is very high AGP, right? So various checklists you can find on the internet, all right? If you don't have in your department, you can have a look at the internet and find it, right? So trachea intubation, Dr. Chan mentioned about it. The less the numbers, the better. Don't put too much equipment inside the room. Okay. So basically, all you need, the main personnel that need is like the intubator themselves, the assistant, and the runner. Other stuff, the unit need, keep them away. All right. Checklist for your intubation. Make sure everything is complete. Equipment, medication check. All right, and plan. All right. If you're going to see that pre-oxygenation, plan A. Re-oxygenation, plan B, and emergency plan. Right, pre-oxygenation, okay, normally we try not to cause an AGP, All right, we want to keep it low. We want to keep our staff safe, even though we are wearing PPE, we are wearing PRP, but try to limit the aerosolization. Okay, so what we're gonna do is that, okay, maybe nasoprong 5 liter and surgical mask on. But most of the time, I don't think patient will able to tolerate this. All right, so next you can use non-rebreather mask, maximum 15 liter, and put the surgical mask on. Or if the patient need higher oxygenation, what we can do is a back valve mask, all right, with PIP valve, viral filter, flex mounting, all right, add 15 liter of oxygen and use of PIP valve around 10 centimeter water, right? When you apply this, all right, make sure you only turn the oxygen supply when mask is fully applied to patient, all right? So this is a setting that you can use. Okay, you can see that there's some adjustment, especially in terms of the viral filter. All right, you can put this flexible mount so that your connection won't be easily disconnected. All right, again, remember, if you're using a back valve mask, right, you need to use two-hand technique, or you can use this strap, right, in order to minimal the leakage. All right, so this is an example of setting. All right, you just put nicely on the patient, make sure it's properly covered, right? You can use this, all right? You can change this. Normally what we do is our non-rebreather plus nasoprong, all right? This is a non-COVID era because this one is a lot of air dispersion. We can change this to this technique, all right? Using the back valve mask, filter, and also the face mask, okay? All right, so again, all right, on top of that, you can add on nasoprong on top of the back valve mask, okay? Dr. Faiz just now said about apneic ventilation for intubation to prevent hypoxia of the patient. Well, in COVID, apneic oxygenation is not really encouraged because it still can produce aerosolization. So if your patient can maintain oxygenation well, try not to apply the apneic oxygenation in a COVID patient, okay? All right, so plan A, good oxygenation, we talk about that, all right? So plan A, all right, so intubation, the difference, all right? We encourage, all right, advocate use of video laryngoscope. Right? Reason why? If you can see that this is your normal laryngoscope, look how close the patient mouth and the intubator compared to this one. Right? We want to minimize transmission. Okay, I think small tips that we need to remember. Okay, during tracheal intubation. Okay, again, you only remove the face mask, nasoprong, or any face mask, right, when the oxygen is completely shut off. Okay. Only attempt laryngoscope blade insertion once the patient is fully paralyzed, right? We do not want to induce cough in this patient and cause aerosolization, okay? If best, all right, if can, all right, do not give positive pressure during back valve mask or during the ETT cuff insertion without fully inflated the balloon, all right? Remember that, okay? And remember to clamp the ETT tube before disconnecting from the BVM or from the ventilator, right? This all to prevent transmission of the COVID-19, right? All right, strategy 3, all right? Let's say you fail to intubate the patient, you need to re-oxygenation the patient, all right? So a bit difference because the aim is to reduce the aerosolization, okay? You can choose apneic CPAP, all right, using your back valve mask with PIP valve, 10 centimeter at 15 liter, plus nasoprong, all right? Most of the time, this is not going to happen because the patient is apneic, all right? So the best, what you can do is that, next, all right, with that back valve mask, all right, two-hand technique, properly seal on the patient face, give a controlled manual ventilation, all right? You give between 6 to 10 ventilation per minute with a pressure of less than 15 centimeter pressure, all right? If not, unable, still not good oxygenation, all right, your next step will be a supraglottic airway device insertion and ventilate the patient. Of course, if you put a supraglottic airway device, please connect again to your viral filter, all right? Right, if let's say all those cannot happen, you cannot intubate the patient, you cannot ventilate the patient, of course, next plan would be surgical airway intervention. All right, so your boogie assisted cricorectomy. All right, I'm not going to talk much about it, but the tip is that while all this procedure being done, you are not to give a free flow of oxygen or ventilation via the oronasal, right, to avoid any air aerosolization or air dispersion. Okay, remember that. Right, lastly, post-intubation care. All right, so again, use end-tidal CO2 to confirm. Very difficult to use your stethoscope, right, to hear the placement of your ETQ. All right, use end-tidal CO2. Closed suctioning system. Right, insert rice tube. All right, whoever intubate, please insert rice tube so that your other colleague won't have to do it. All right, apply clear plastic sheet to cover the patient mouth and nose. Always remember your viral filter. Again, your ventilation you should apply again standard practice, your lung protective strategy. Right, so this is how you put, all right, at least, okay, what you do, your HMEF filter, right, your heat moist filter, and towards the patient, okay, and your viral filter at the expiratory outlet of the ventilator minimally, right, so to prevent any transmission. Aerosolization box, all right, early on the COVID year last year is very popular, but actually it's find out that this is no evidence to reduce droplets or aerosol spread, and it actually can worsen the ergodynamic and increase difficulty of intubation process. So, right, so I think just plastic will be good enough, right? No need for this aerosolization box for intubation. Okay, for CPR, all right, so not talking too much, but I'm just going to highlight you. All right, so this is study again, all right, if you can see, CPR, yes, is a AGP, aerosolization generating procedure. You can see that without surgical mask, chest compression, right? So you can see there is a air droplet being produced. With surgical mask also, yep, some dispersion happen, right? If you tube the patient, all right, you can see the very eject nicely, but if apply filter nicely, you can block the aerosolization, all right? So what between, okay, so CPR, if the patient basically have an advanced narrative, have a futile condition, stop, do not attempt CPR at all, okay? Only do CPR in a indicated patient, which is really, really difficult if you're in emergency department because you basically don't have much information about the patient, right? So what you do, right, so this patient, CPR should be done again in a full PPE, all right? So if a basic life support, okay, patient responsive, call for help, look for a sign of life, but do not open the airway, right? Do not listen to the, do not listen or breath, do not listen or feel for breath, do not give mouth to mouth, definitely no. All right, look for sign of life, right? If no, apply a plastic sheet and perform CPR, right? You should not attempt any form of ventilation without full PPE. All right, then apply your AED and follow your AED for your basic life support. Right, for your advanced life support, right, they advocate more. All right, you should prioritize to intubate rather than to give a backwash mask. All right, you should prioritize for intubation to reduce the aerosolization. Okay, so airway, intubate early. If not, use a supraglottic airway with a viral filter. But if you cannot and you have to use backwash mask, all right, again, use viral filter, need a good seal with 2% VE clamp, all right? So you really need to. Tips, all right, stop CPR during intubation or insertion of SGA, all right, cover plastic sheet with endoscope and minimize closed circuit disconnection. Again, consider mechanical chest compression devices, right, for your CPR in COVID patient or suspected COVID. Okay, just bear with me. All right, so this is again regarding sepsis and pain guideline. All right, I talked to you about in terms of breathing and oxygenation. Okay, not going to go through that again. All right, in terms of ARDS, right, remember our the concept of H and L type. All right, if your patient more moderate to severe ARDS COVID, then it's I think the management would be the same as your normal ARDS. Okay, not much difference. In terms of sepsis, septic shock of COVID patient, again, same concept. All right, you manage as per sepsis and septic shock management. Okay. All right, so again, we are finishing. All right, extra COVID-19. Okay, there's a lot of studies. I think if not thousand, maybe hundreds. Okay, regarding antiviral, corticosteroid, immunotherapy. Not going into depth because there is so much controversial about it. Okay, I'm not going to, but of course, there is evolving knowledge. All right, so not going to. Again, stabilization as normal, okay, as any of your critical ill patient, all right, fast hub in back, please. All right, you can read that to yourself. Okay, this is my final slide. All right, so with the knowledge that you have just now and a bit of knowledge about COVID, all right, so your management, your aim will be the same, all right, the goal and therapy will be the same, but with an extra precaution. So if you're in emergency department, all right, from the pre-hospital, the triage, the resuscitation area until the patient is disposed from your department, you need to think about this 3S concept, okay? Always protect yourself, protect the colleagues, all right? Protect the patient, the other patient from the risk of transmission. Okay, with that, thank you.
Okay, thank you, Doctor. So we have a question here. What is your first line induction choice for drugs?
First line induction, I think it would be the same with your RSI for your COVID. All right, so induction, it depends on the hemodynamically of your patient and how familiar you are with that type of induction agent. I think it will be the same. You can use if basically same, depend hemodynamically and the availability and how familiar you are. So not much difference in terms of your RSI induction with COVID and non-COVID.
Okay, I think the doctors answered the question. So I think that's all for today. So thank you so much, Doctor, for generosity of the knowledge sharing. So today we will end our session for first day session, and we would like to say thank you again for all our presenter. Please give them a round of applause, okay, for their time for us and sharing and all. So it's really interesting talk. And then hopefully the presentation that we have today will be beneficial for everybody. And don't forget our second session tomorrow, as the link being given already in your email. So please do check your email. And the next one is, I would like to remind to all of you to check the catalog inside the Telegram that will from the SMS Medical ad. So they shown some of the catalogs there, so you guys can have a look. And also for the regarding the recording that we have today, that you guys can go to the YouTube channel or official Facebook page, which is the Malaysia Paramedic Emergency Critical Care Alumni. So for those who would like to watch again whatever that we have been recorded for today and tomorrow, you guys can like and share at our Facebook page and also YouTube channel at Malaysia Paramedic Emergency Critical Care. Okay, so and also remember tomorrow by the end of the session we will be release our feedback form. So please be aware to respond the feedback form. If not, you will never receive your e-certificate. Okay, I repeat. So please ensure yourself to be alert to fill in the feedback form that will be released inside the Telegram group after tomorrow's session. Okay, the committee will send out or blast a link of the feedback form, and please make sure that everyone need to fill it up to ensure that your certification will be received soon. Okay, so anyone who not being incomplete, okay, organizer won't be entertained, so you won't get any of your certificate. All right, so I think everyone's hungry. I can see the music from here. All right, so thank you so much everyone for your time. See you guys tomorrow, same time. differently. All right. So hopefully to see you again tomorrow, and have a great lunch, everyone. Assalamualaikum, and see you tomorrow. Bye bye.